Thanks, Pierre. First of all, I wanted to thank all of the speakers for just a great day today. But I had a question for Dr. Slotz. I couldn't help think when you're speaking today. Some years ago, I got a hold, maybe 25 years ago, some audio tapes that described two virostat drugs, one being, I think, metronidazole, and I forget what the other one was. But I believe they talked about metronidazole or Flagyl as being a virostat drug in relation to DNA-based viruses. It may have been RNA. This is what they were claiming back then. And when we do DNA testing for our periodontal patients to see what, not DNA testing, but the testing to see what microbes are there using the PCR, that metronidazole comes up, of course, commonly as a medication to get rid of the bacteriology. My question to you, is metronidazole working on both the viral and the bacteriological ends of this thing?
I have never heard that it works against the virus. You're right, it is the DNA toxic product. It works against protozoals. That's how it was developed. Right, for the protozoals. Yeah. And then they later discovered that it was a good drug against anaerobic bacteria. There may be literature about the viruses. I have never met that literature. Okay. I have never seen it. It works against the DNA, you're right. And the virus, the herpes virus, has a double-stranded DNA. Okay. So it is not maybe unreasonable to believe, but I cannot recall I have seen any literature about it. Okay. But, you know, there are thousands of articles. I may have missed it. I can look it up.
Okay. Thank you. Yep.
Pierre, if I could say something, I want to correct a misstatement that I made this morning regarding the work of Dr. Mullenix. I mistakenly said that the results of her rat studies was cancer. That was not the case. That I was thinking of Marcus still. Her results were more cognitive function problems. There was motor dysfunction and IQ problems. Those were the results of her case. So, yeah, to the fluoride, I just want to clear that up so it's on record. Thanks. She's going to be in Vegas, right? So thank you for not standing up and saying wrong when I said it.
I have a question for Dr. Margolis there again. You were talking about in doing the surgery and, in the NICO surgery on ones that have been on bisphosphonates, or have been on bisphosphonates. What is your criteria as far as time that they've been off, length of time they've been on? I know my understanding is that the IV forms, usually after breast cancer therapies and things like that, are much more of a concern than the oral because of the poor absorption levels, that sort of thing. It's just my part. But at what point are you treating, not treating?
I'm not treating them.
Or what?
I am not treating any bisphosphonate patients for human bone ischemic disease, jawbone disease. I send it to an oral surgeon. And this is why. Being a biological dentist and having all the fun in the world that I could ever want for a lifetime with the state board, and just writing a treatment plan and never even doing any treatment on a patient, that cost me a tremendous amount of money and time. The best thing I got out of it was my wife. So, yeah, she was my attorney. So what I do when it comes to bisphosphonates is I refer them to an oral surgeon and let them have the headache. I have plenty of other patients that don't have that. We, as a group, when we did the studies for the FDA on the cavitat, we did a study. There was 5 or 6 practitioner clinical people, myself, Wes Shanklin, Bill Galeros, and 3 other people, submitted samples. We found that we had generally 75% of the areas that we scanned were healthy, 25% were not. And it was backed up with over a 99% accurate rate. When it came to the bisphosphonate patients that were done by 2 or 3 other people in an institution, they found that the occurrence rate was over 80%. And then I gave the story about the oral surgeon who fractured a jaw. So I stay away from bisphosphonate patients. I have enough on my plate. I don't need to do this and get a headache because we just don't know if they're going to heal. And I don't think, the first thing that we do is no harm. And if I'm not equipped in a hospital setting to help these people, then I think I could hurt them, and I will not do that. The half-life of a bisphosphonate drug, I was told, was 29 and a half years. So if they live 29 and a half years after having that, maybe I'll consider it. And I hope in another 29 and a half years I'll be retired. Maybe.
I'm sorry, I was out there. I missed part of that. I just came out of the lecture on ozone. I'd like to just have maybe a discussion here. Yeah, with maybe Phil was talking about treatment that he's been doing with these bisphosphonate patients.
Well, I don't know, unfortunately or not, we've been welcoming and looking for bisphosphonate patients. First of all, Mike's right about doing no harm, and that's why we've taken more of a biologic approach to it and support the healing process. We better understand the pathophysiology associated with these lesions. We're supporting the health and maintenance and the integrity of the good, healthy tissue while the body goes through this healing process. And like I said, there's a sequence of events I've seen again and again in these patients where if you maintain support the health and well-being of the tissue around it, try to get them re-regulated, functioning properly, the body will actually cleave this bone off on its own. It will separate the bone out of the osteonecrotic area and actually evulse the tissue. Once that bone, as you've seen with that picture, where it was a pretty dramatic hunk of bone that came out and a couple of fragments associated with that, then we were able to control the infection. Of course, that's the primary thing on the runway. And then the area healed very well. Morphologic, anatomically, of course, that area changes dramatically. This gentleman that I showed you in particular lost half his maxilla. But the point is now he's infection-free. He has very tonified, healthy gingival tissue, epithelial tissue covering the wound site, and it's healing. So you can't take intervention. It's a very supportive and maintaining the health and well-being of the patient as that healing process goes on. They will heal, but you have to support them properly. And the primary thing, once again, on the runway, and this is where the oxygen ozone and the supportive therapies come in so importantly, is controlling the infection. Like I said, it's not really, I don't want to say as simple as an osteonecrotic infective lesion that's sealed with soft tissue. But the problem is that when the epithelium desquamates and opens up into these bony lesions in the oral cavity, now we're dealing with multiplicity of infection until, once again, we get the cleaving and relief of the bone and then re-epithelialization of the area and then proper healing. So that's been our effect.
Okay, this is for, for Dr. Cole regarding fluoridation. It's come to my attention in the course of doing some research that the sorry state of the Medicaid program is being used as a pretext to put fluoride in the water. We can't do anything else for these kids, so let's dump fluoride in the water. You have to see this to believe this. And I wondered if you were aware of that and how if you were, like myself, hoping to be a lobbyist, how do you confront such an a weird situation without appearing to be classist, because that is the way they have engineered it to look.
I'm not aware of that, but I am aware that one of the last issues that our President Clinton had decided before he left office was to get the rest of the major cities fluoridated. That was something he had signed off on. That I do know. And one was San Diego, one was San Antonio, as well as a few others. So that was just a government-driven thing there. I'm not sure about the Medicaid thing. Maybe David Kennedy in the back knows that. I don't know. So.
David or Jeff, any comments?
I didn't hear the full question.
You had a question? Okay.
No, I didn't hear the full question.
Oh, could you repeat your question then? Perhaps someone back there.
Okay, I will repeat it in this direction. It's come to my attention that the poor state of the Medicaid program and a lack of access by a lot of low-income children to good dental care is being used as a pretext to fluoridate in many places. It's a strategy. It's a political strategy, and I just wondered if you were aware of that and how you would advise confronting it without appearing to be classist, if possible.
Well, the difficulty is the whole thing is a fallacy from the very beginning, and so there isn't any doubt that the American Public Health Association is determined that they're going to utilize all of their efforts, and so is American Dental Association and the rest. And so every one of these things are just about how they use part of the system. And so anything where they can claim that an indigent person doesn't have access to fluoride, which if anybody's listened to any of the other information that's come out, shows that it's in cereals, it's in foods, and it's in drinks, and it's in everything, and people being overdosed even in non-fluoridated communities. So the ways that we've addressed this in other places is asking health departments to identify the populations that don't have access to food. And you actually name the foods and ask them what happens. And none of the health departments in New York State, in Tennessee, in Nebraska, I mean, there's a number of other states we've asked these questions of, and they've never been able to respond at all. And so, it doesn't resolve the problem totally because you're still asking a question, but they're really clear about the fact that they don't have an answer. I mean, they know that part.
A quick story. In 1979, I wanted to get educated about this issue. It was about that time, and I went to George Martin, and George Martin was the deputy director of the Dental Institute. And I asked him about fluoride, and he took me next door to a locked room where he had 6 file cabinets, 4 drawers each, full of information about the problems of fluoride. So I said, who knows about this? He says, well, when it's timely, we'll tell. And I think it's not quite timely yet, but if you keep asking, maybe they'll tell.
Thank you, Dr. Jaffe. Have any more questions for our panel? Run here.
Yes, Dr. Kennedy. When will your DVDs be available, the ones we saw last night? And how do we access them or purchase them?
The question was about the DVDs. They're all available now. The DVD you saw last night is available from FAN. The one about China is available from Kim. So Fluoride Action Network did the professional perspectives. Kim has a 4-part DVD. You saw the first part last night. So they're available now. Go over and get them. Woohoo!
Thanks, Dr. Jeff Kennedy. Questions for our panel? One up here.
There's so many things about fluoride that are over the edge, arrogant, I guess. But one that really bothers me is the fluoride varnish. And fluoride varnish is one of the new trumpeted products by the public health establishment. And this varnish is being given to children who just barely have teeth, period. New teeth, toddlers. And it's not just, like a sealant on a few pits and grooves. It's the whole tooth that gets varnished. And it's in good flavors, so the children tolerate it. It's, nice flavored, sweet flavored varnishes. I've seen them advertised in the ADA news at 22,500 parts per million, and the varnishes can be applied as often as 3 times a year. So where does that fluoride go if it's being reapplied and reapplied, and they get it 3 times a year? You know, this is not like the gel, which is bad enough, where you rinse and spit. This is fluoride that's going to go into that child's body, and it's a toddler. And with all the science that we've had, like in the NAS research publication of a couple years ago, the hormonal impacts, the neurological impacts, the skeletal impacts, on and on and on, dumbing down our children and going after these vulnerable toddlers and targeting low-income and disadvantaged children with this for a quick buck. And you don't even have to be a dentist. You can be a doctor. You can be in a doctor's office. Anytime they walk in, you get them with this fluoride varnish and act like you're doing them a big favor. So I think it's just good to be aware of this. This is spreading. I've heard of adults getting this treatment too. And, you know, we just simply have to get out there and educate about fluoride, that it's a poison. That's the message. It's a poison, not a nutrient, not a benefit. And would you use lead or arsenic varnish? Fluoride is almost as toxic as arsenic. We would not use arsenic-coated varnishes.
Thank you. It's Leo Cashman from DAMS. Another question here.
Yes, back to our distinguished panel. I have a question that would involve at least 3 of you, and that would be Dr. Margolis, Dr. Malika, and Dr. Harris. I'm going to stir the waters. If I find a patient that I'm sure has a cavitational lesion, say from an extracted 3rd molar, she's 55 years old and female, not having any pain, how would you differ in your treatment? Would you do just ozone treatments maybe multiple times, 10, 12 times, or would you do ozone treatments and then follow it with surgery, or would you just do surgery?
Go ahead, guys, you start.
Me? Okay.
Yes.
I wouldn't do surgery on it ever because it's unnecessary in those areas. If you have an infected area and you can get to it, you put an X-tip in there, whatever you need to do to get in there, and you put ozone in, it'll kill your infection off. You shut down that acid response from the infection. You allow the body then to create an environment in there where calcium, magnesium, phosphorus can go back in there. Ozone promotes stem cells in the marrow. So you'll get new stem cell production, hence new bone production. And it's proven in several studies that fibroblast production is upregulated by ozone because of the amount of oxygen released in the area. Nitric oxide is released, increasing your blood flow. So overall, you get a total physiologic response that's conducive to regrowing the bone as long as the infection is controlled.
How would you evaluate that the bone is regrown? You would use your 3D imaging that you have?
Remineralization and radiographs, 3D cone beams.
The 3D cone beam is probably your ultimate?
Absolutely.
Okay.
Yeah. Phil has an ICAT, and we're following a lot of these cases now with the 3D cone beams, especially the old endodontically treated teeth, and how the radiographs will show no lesion, but a 3D cone beam will show a lesion on the tooth. So let Phil address that a little bit too.
Well, it's very difficult to follow brilliance, but I will try, Dr. Harris. Thank you. I was. That's what I was talking about. Well, our approach has really been, biologic, non-surgical approach to these particular lesions. And, we found it's been in combination. We're working with an oral surgeon out in California that we trained. And he's doing a combination of things. He might treat it, just ozone-wise, or what he'll do is there are preconditioning techniques where you treat the lesion preoperatively to reduce down the infective state, then maybe debulk the area if necessary. So I'm kind of in between where, in my cases, I do not go in there surgically. I don't find the necessity for it. Our protocols have been refined enough for these contained infective lesions, and the science is supportive of that to allow these. Now, The trick that we see is we start to see remineralization. We know that we have the infection under control and the infection is eliminated. And also the most important point is that if you once again go back and understand cell biology, microbiology, pathology, you have to recognize that this little focused area of infection is just not a focused area of infection. It's just not in that little spot. And if you think by going there debulking it and let it stand alone, that's going to resolve the infection, that's impossible biologically, okay? Where now we know the ozone will follow these pathways based on its biochemistry and physics, where all the positively charged areas and eliminate the infective state in that particular area. Now, as far as ultimate resolution, you know, once we see remineralization of the bone, now we know the infection's shifted, the pH has shifted, and we're getting recrystallization. Does it sometimes look like it's been the ultimate perfect remineralization? No, not all the time. But importantly enough is that if we see that remineralization, we know we have the infection eliminated. And what's important in this type of therapies, the importance is control and elimination of the infection and changing the ecology that's going to promote health and wellness within that bony structure itself, and therefore that translates out to the rest of the body. Did I answer that question?
Yes, thank you. And now
Okay.
Dr. Margolis.
Yes. Control of infection. Elimination of infection. I've gone through and I've done the ozone classes with the two gentlemen. I've read and done some of their procedures, and I have taken patients who had lesions around teeth and had the third molar areas that were obviously infected. And I told them that I would treat the teeth and then we would be doing the surgeries on the third molar areas. And after 10 visits and nutritional support and also using infrared, trying to support it the best that we could, I went in and did the surgeries. And I found that the ozone shrunk everything and it looked a lot better. I can't tell you how many times I've seen root canals done, remineralization around the apex of the teeth, and then gone in and taken out the root canal and found huge infections in those areas. And I think anybody who has ever done this can also have had that same experience. So what we see sometimes on an x-ray could be just wishful thinking. Now, if you want to control infection and not do a surgery on a 75-year-old woman, and they're willing to come in periodically and do that, that is a course of treatment and might be very good in her case. I have had people that age that didn't want to have surgery, and I believe the patient has a right to do what they want. But I've also had 80-years-old people come in, and we've done the ozone and we've done the nutritional support. I belong in a state that have naturopathic physicians who graduate from naturopathic four-year universities. We have MDHs, homeopathic physicians. They have them on many different routines. So I don't have to design a support program. They're already on it. And these doctors asked me to evaluate and see if you would take them out, remove the teeth. Now you have to be careful if you're using a cavitat on that, because if you're injecting ozone, you'll get false positives. It will look just fine, but due to the fact that you've increased the blood flow in the area, it looks healthy, and the cavitat's giving you a false reading. So you have to listen to the patient. You have to take into consideration the situation. But I would have to ask the gentleman, what are your biopsies showing you? Because I have a 3D cone beam Galileos in my office, and we've done all these little different things, and we've had nutritional support, and depending on how well you use that machine, it seems like I can always find a lesion somewhere around those teeth, and when I go in and take them out, there's always a little abscess or a little dead granulation tissue present. Not 90% of the time, but always.
Thank you for all three of your answers. I'd like to ask, too, if any of you are using thermography of the head and neck to find osteocavitational lesions.
Let me start that real first. I don't have that unit in the office, but there are a number of centers in Phoenix, and that's how many patients are referred to me.
Thank you.
Well, we could clear one thing up with Dr. Margolis heard Dr. Malik and I speak at Capital University on ozone, but he's never physically taken our level 1 or level 2 courses. So how we do this now compared to what we did in 1998 and 99 and 2000 at Capital University is totally different. And, you know, how do you ask someone after you're getting resolution on an X-ray and a 3D cone beam, say, now that you're getting healed, let us cut your jaw open and take a piece of bone out and see if it's healing? I mean, who would really, what patient would really want to do that?
Well, if the research that I'm familiar with that isn't, I don't know how well accepted it is in the protein degradations and osteocavitational lesions, that's where the P53 protein breaks down. If someone is facing cancer surgery or maybe do preemptive cavitational surgery, I'd go for the cavitational surgery before they take big parts of my body off.
I didn't get that.
Well, you know, if I think cavitational lesions are just really tough on your body and your immune system. And I think as we get more into treating these, I think we're going to recognize more that there's direct links to malignancies from these lesions.
But wait one second. You didn't give us that condition on
No.
that one lady, and I want to make
No.
that very clear. What Dr. Harris and Malka are doing, I'm not criticizing. I'm not saying that it's wrong. What I am saying is the experience of what I've had in the past, and I've had people come in with the technique of ozonated root canals and treatment, and they've gone through all the classes and everything, and the patient comes in, they're having problems, I take them out. I don't know if the person did the procedure correctly. Maybe it was a cracked tooth. But, you know, as Robert clearly said, if the patient's doing well, do they really want to go in there and open up the bone and check to see if it's right? So I'm not trying to sit there and say, gee, golly gosh, you're wrong. What I'm saying is, in the parameter of the question that you asked, is, yeah, it'd be difficult to do. It's going to be up to the patient to decide what they want to do. But I had the situation where we had already agreed, and I was charging all of $28 to ozonate their entire mouth. That could have been up to 10 to 20 sites. It didn't matter. So it wasn't a financial decision for them, for the ozone. And I honestly believe in the areas around the teeth that were in question, that were going in the wrong direction, that the ozone did turn the situation, the environment around those teeth around. But yet, I haven't found ozone to be the cure-all. And even though I have seen a number of root canals or teeth that have had apical lesions resolve very nicely, but we still had some problems, I went in and I always find granulation tissue and an abscess. So those are some of the problems.
Well, thank you very much. I think we don't know all the answers yet, but as you guys do your studies, I think we're going to know more. Thank you.
Thanks. We are at the beginning of this. That's right. Questions again, please.
Dr. Malika, on the case that you showed, did you have him wearing any sort of a temporary partial or anything to keep that area covered?
Well, what we did, part of the protocol that we did was that, no, you can't really put a partial on it. You can't pressurize the tissue, that's for sure, when you're trying to induce regranulation of the epithelium. What we do as part of their care is we actually make rubberized trays, like suck-down trays, and create a well over the lesion. And what we do is actually take ozonated olive oil, the ozonated oils, and place it within that well so that the area is being soaked in that oil, especially overnight. So this is where we can, get, low infection rates down there. So we use actually trays. And the ultimate thing is that, especially when you're seeing in these denture cases with these bisphosphonates, the pressurization of the denture is actually desquamating the epithelium back. So no, because that gentleman, as we fixed them, and you're seeing the dramatic changes in that tissue, he says, well, can I have teeth there now? I said, well, first of all, your sinus is gone. This is the ceiling of your sinus we're dealing with. The floor is on the tray. And No, you really can't. We don't know. We're not going to go back and start putting prosthetics in there until we're actually really comfortable that we have this really nice, complete healing. I don't think we'll ever get in that particular position. But yeah, for treatment-wise, we do take those oils, which are very potent, and have the area soaked overnight.
Perhaps Dr. Kennedy might have an answer. Your picture, well, I've read a number of places that the human body has the potential to renew itself every 9 years or so. Every cell in the body, they say, can renew itself. But obviously, after seeing your photos in China, that didn't happen there. So do you think there's a reason, or perhaps can fluoride be eliminated? Fluoride, damages and harm can be eliminated with time? Or is it permanent? There's a memory, it just won't happen. Does anybody know, can the body totally replace itself and heal itself?
Anybody on the panel have the answer to that one? That in China, they improved dramatically when they got them off of the 4 part per million water, and that the pain reduced, but they weren't able to reverse the skeletal deformities because that is a permanent injury, because the bone is chock full of fluoride. That's where your body stores the fluoride. Fluoride is not a nutrient, and so it basically has to be parked someplace, and that's what destroyed the skeleton. The antidote to fluoride poisoning is calcium, magnesium, vitamin C, selenium, and iodine. So nobody actively treated these people. They just took away the source of exposure, and they got better. They didn't get well, but calcium, magnesium, vitamin C.
Cocktail. Question. Johnny.
This goes to Dr. Schlotz and to Bill also. I think it was just very informative about how the synergism between the viral and the bacterial that we're looking at, what's going on there. How close is the biological perio techniques we're doing now? How much are they addressing both? I mean, obviously we're seeing healing. How much is it addressing the viral aspect of that also?
If you remove or reduce inflammation in gingiva, then you remove the mammalian cells by which the viruses are coming in. And that's probably one of the major reasons that our oral hygiene works, because there are fewer macrophages, T cells and B cells coming in when you reduce bacterial plaque and reduce gingivitis. Now in big lesions, long deep lesions, you probably have to have an antiviral drug to be sure that it's all removed. And that's where we recommend Valtrex to those particular patients. The methods we are using in terms of treating today is an indirect method only in removing the viruses. Valtrex is the direct method. The indirect methods worked in many, many patients, especially in the early stages of periodontal disease. But in the later stages, we probably have to use Valtrex or another antiviral drug, acyclovir or whatever, to eliminate the viruses. The viruses is a major medical health problem, I believe. I think that the association, as I said, between the oral cavity and cancer and all those things, heart disease, premature birth, arthritis, is through the viruses. And dentists are uniquely qualified to deal with those viruses in the periodontium. So I think this is a major task for dentistry in the future, to deal with the viruses in the periodontium, and by that way dealing with a lot of medical diseases of the most severe type. And I don't think it's a dream world only. I think there's a lot of reality to this.
So if we're seeing advanced periodontal condition and on the scope we're seeing a lot of pathologic bacteria, you would automatically treat them on the Valtrex also?
No, I will only treat with Valtrex if the patient is progressing, losing bone. If the patient is stable, you can have many people that are stable and have all those bacteria we talk about. They're not losing bone because they have no virus or very low level of the virus. If they are losing bone, we know from at least 10 studies that they have a lot of viruses. They have millions of viruses in those pockets. That's the point to go in and treat with Valtrex.
Thank you.
Your question's answered. That's all that needs to be said.
I'd be curious to find out your answer on this, Dr. Landers.
First, I'm not a doctor, so thanks for
I'm
the
sorry,
honorific, but unnecessary. It's a compound problem. You have a viral problem with a bacterial host. The virus can't exist without its mammalian cell hosts and the bacteria associated with that. I think what Dr. Slotz is saying in other terms is that if you can control the infection with a purely antibacterial approach, all to the good. Going beyond that, you may need to use the antiviral drugs. The point for me is that how do you know when to make that decision? So better testing methodologies is necessary, or you're overtreating the patient.
Yeah, the risk of overtreatment is always present when you don't have a microbiological, biological diagnosis. But the risk for the patient is very low. The medical risk is very low because Valtrex is such a benign agent. It's a little expensive, and maybe we can use acyclovir, which is, Valtrex is a further generation of acyclovir, and acyclovir is dirt cheap. But the studies that have been done until now are done with valcyclovir or Valtrex. Valcyclovir is the generic name for Valtrex. But if people say they believe it's too expensive, and I have had dentists that complained about that, then maybe it can use acyclovir. But acyclovir is not absorbed so well in the intestinal tract as valcyclovir, as Valtrex is. So that's why in the scientific studies we preferred Valtrex. But it may be sufficiently absorbed, we don't know, acyclovir. But I feel that an organization like this one, who is interested in the medical aspects of dentistry, that's really what you are when you talk about fluoride and you talk about mercury. You are interested in the medical aspects of dentistry. This here is a major task you may consider to take up and develop further, because I think it's a very solid concept, and if we can implement that in dentistry, we will have a whole new area of activities in our office which can help patients probably tremendously.
Great insight. Thank you. We'll take one more question, and then we'll go to the reception.
This is a quick question, so maybe you can get a second. I would just like to know if can we determine viral presence only through soft tissue biopsies? Can you do it with sampling plaque?
No, because they're too small. You have to use electron microscope. Then you can see it in the tissue, and the tissue is loaded with it in those severe cases. That has been established. But in the light microscopy or phase contrast microscopy, dark field microscopy, you cannot see them.
So right now we'd have to cut soft tissue samples and send them for...
No, you can take paper point samples and put it in the pocket and see it, but there's no laboratory in dentistry that will be able today to do that, to do this diagnosis, because it is prohibitory in terms of cost.
Okay.
Dentists will not pay for it.
Thank you.
Thanks to all our speakers for attending today, for attending our forum. Thank you so much. Thank you for your questions.